Welcome to the DeBakey Cardiovascular Grand Rounds. We have a great talk ahead of us. I would like to thank all our attendees from Methodist, Texas Children's, Herman, Texas Heart, who are here to see our speaker. It is an honor to introduce today our speaker, Dr. Wendy Book. Dr. Book is a professor of medicine at Emory University School of Medicine in the Division of Cardiology at Emory. She's also an adjunct professor of epidemiology at Emory Rollins School of Public Health. And she is the founder and past director of the Emory Adult Congenital Heart Disease Program. She led the program for 20 years, from 2001 and 2021. Dr. Book is a true national pioneer in the field. She has 26 years of experience caring for adults with congenital heart disease. In addition to ACHD, she is a heart failure and transplantation cardiologist. She completed her fellowship training in cardiovascular disease at Emory University in Atlanta, and she's board certified in internal medicine, cardiovascular disease, advanced heart failure and transplant, and adult congenital heart disease. Her research interests are CHD surveillance systems and Fontan failure. Dr. Book's works have been recognized in numerous publications, and she has received multiple awards, including the Emory University School of Medicine Alumni Award and the Nanette Wenger Distinguished Service Award for outstanding contributions to Emory University School of Medicine for the development of the Emory Adult Congenital Heart Center. In her spare time, Dr. Book is a volunteer since 2009 as a board president for the American Partnership for Eosinophilic Disorders, helping bring diagnostic criteria and new therapies to improve lives of individuals with eosinophil-associated diseases. Dr. Book has trained and mentored generations of ACHD cardiologists. Her mentees are all over the nation leading the care for ACHD patients. She has shaped their careers. As soon as they heard she was coming to visit Houston Methodist, I started getting messages from all over the country claiming that we're about to receive in our grand rounds the best of the best. Some of them are very respected ACHD cardiologists, and they all agree that she is an unparalleled clinician and educator. Her pioneer work in developing ACHD registries and collaborating with other institutions has been groundbreaking for improving the outcomes of ACHD patients. She's been working tirelessly with organizations like the CDC, and she has been focusing on improving access to care. She has definitely made a profound difference in many lives. Welcome, Dr. Book.
All right, thank you for that kind, very, very kind introduction. It is an honor to be here today with you all. Houston is one of the great places for medical care, for cardiovascular disease care, and for congenital heart disease care across the spectrum. So it's truly an honor to be here today with you all to talk about Fontan failure. This painting is from one of my trainees, Jenny Girardin, who's currently at University of Wisconsin on faculty there, and she is a true artist. Those of you who do CHD will recognize the diagnosis. So, in the interest of time today, we cannot possibly cover everything there is to cover in Fontan failure. And I'm going to focus on the impact of Fontan physiology. Is my mic working? Yeah. Okay. On end organ function. Describe some of the phenotypes of Fontan failure physiology, and how to manage by that physiologic presentation. And then we'll talk some about risk benefits of advanced therapies, which is where many of these patients go. I have no financial disclosures. I am an adult cardiologist. My bias as an adult cardiologist will come through loud and clear. I will talk a little bit about what goes on in pediatrics, but I definitely have that adult perspective on the topic of Fontan failure. And anything I discuss related to treating Fontan failure will be off-label, including device usage. As we all know, the Fontan operation is a palliative operation, and it has allowed children with single ventricle heart defects to survive through childhood into early adulthood. But that altered physiology leads to premature morbidity and mortality. The complications after the Fontan operation are numerous, and we won't have time to get into all of them. I'm going to focus primarily on ventricular failure and Fontan-associated liver disease, but there are many other very important reasons these circulations fail, including protein-losing enteropathy, plastic bronchitis, AV valve regurg, arrhythmias, cyanosis, venous insufficiency, the list goes on. And I'll talk a little bit about the role of transplant, I don't have an answer on the timing for transplant, but we'll talk about that a little bit and show you some promising new treatments coming down the pike. So those of you who do this day in, day out are familiar with the Fontan operation, but for those of you who are not, basically these patients with a single ventricle have, I knew I shouldn't have touched the mouse pad. Here, we'll do this. Have the SVC and IVC connected directly to the pulmonary artery, bypassing the heart. And today, this is typically done with an extra cardiac Fontan conduit. So you have passive, non-pulsatile venous flow to the pulmonary circulation. You have one ventricle, which pumps to the high-pressure systemic circulation. And this sets up the situation for Fontan failure at the end of the day. So the Fontan operation upends the normal physiologic relationships in the venous systems of the circulation. In normal circulation, those of us with two ventricles typically have a relatively low right atrial pressure. We have an RV that assists as a pump to the pulmonary arteries, going into a relatively low pressure left atrium. From the day the Fontan operation is done, the right atrial pressure has to be higher than the left atrial pressure. There has to be this downhill gradient in pressure in order to circulate blood through the pulmonary system. On top of that, it is non-pulsatile flow. It is laminar static flow. And this leads to hepatic venous hypertension. So hepatic veins have high pressure. Hepatic veins are dilated, the liver is congested, and this sets the stage for the physiology that we see late after the Fontan operation. On top of that, in the absence of a pump to the pulmonary circulation, the ability to augment cardiac output is limited. And in children, they typically do pretty well in terms of their ability to exercise, but as time goes on, their ability to augment cardiac output declines. Left atrial pressure in children is very low. Even with a single ventricle. As we age, everybody's left atrial pressure goes up, and as your left atrial pressure goes up in a Fontan circulation, so does your right atrial pressure. This probably will be most of what I'll talk about in pediatrics. This is pediatric long-term outcome data. And this looked out 20 years. I will caution that they only have 34 patients at the 20-year mark. So this may be an overestimate of how well these patients do long-term, but you have about 74% survival at 20 years post-Fontan, and about a quarter of the children have died by 20 years post-Fontan. And then you've got a small number that have been transplanted. So while the outcomes are great early on, long-term, we have Fontan failure. Why do these patients die late after Fontan operation? Well, there are numerous causes of death. Most of them are cardiac, some type of heart failure, circulatory failure, sudden death, and then a smattering of other end organ complications, including renal failure, thromboembolic complications, bleeding, protein-losing enteropathy, liver disease, and malignancy. So it's a whole host of problems. This is data we presented at the AHA, and this just shows the comorbidity burden that these patients experience. We have school age, adolescents, young adults, older adults, and I hate to call anyone 31 and up older, but that is what it is for this population. And this is at the beginning of a 10-year surveillance period, and this is at the end of a 10-year surveillance period. And we looked at dysrhythmia, cyanosis, liver disease, and heart failure. And you can see the school-age kids have a very low comorbidity burden at the beginning, but by the end of the study period, that jumps up significantly, most everything doubling, some even tripling. And the same with all the other age groups. Most importantly, by the time these patients are in their 30s, 80% of them have multiple comorbid conditions, many of them concomitantly. So all of this contributes to late Fontan failure. So before, that sounds so gloomy, so we're going to look at cute puffins and talk about the concept of the super Fontan. So the super Fontan, this is a Japanese study, and they looked at outcomes of kids who had good exercise tolerance and preserved end organ function and labeled them super Fontans. And you can see their survival is excellent and their hospitalization rate is lower than those that have poor exercise tolerance and have end organ dysfunction. That's not a surprise. So the characteristics of these super Fontans, though, are interesting. There are features we can't do anything about, like male sex, being younger, not having heterotaxy. But there were some important things that came out of this study, including a favorable BMI, making you more likely to be a super Fontan, being very active in daily life, so daily exercise, and better glucose tolerance. So all of these things are modifiable lifestyle factors that the pediatric patients can start early in life, and it may help them have a better outcome long term. That being said, they did not find any super Fontans after the age of 30. So while you might be able to help the younger patients do better longer, eventually end organ dysfunction kicks in adulthood. The other interesting thing from this paper was that the super Fontan patients did not necessarily have a low Fontan pressure or normal Fontan pressure. Some of them had high pressures. And some of those with low pressures had end organ dysfunction. And we see this clinically all the time. You have the patient with perfect hemodynamics, and they're not doing well clinically. So he confirmed that, but did also note that you had to have a low EDP to be in the super Fontan group. So my daughter took this picture. She likes to scuba dive with sharks for fun, and assures me they only eat people by accident. So that makes me feel better. So she took this photo. So let's talk about Fontan failure. How we define it varies. If you read any paper on Fontan failure, probably the definition differs across authors and centers and across time. I think we really should think about it as a spectrum similar to the way we do with heart failure, with stages of asymptomatic pre-Fontan failure and symptomatic Fontan failure and end-stage Fontan failure. For the purposes of what I'm going to talk about today, we'll use the Australia-New Zealand definition, which is death, need for heart transplant, protein-losing enteropathy, and advanced poor functional class. I also would say that having refractory ascites requiring paracentesis indicates Fontan failure. Developing hepatocellular carcinoma, I think, is an indicator of a failing circulation. And those that need recurrent cardiac hospitalizations. The number of which per year predicts a poor outcome, I don't know yet, but I hope to know soon. And refractory arrhythmias that are unresponsive to multiple ablations and anti-tachycardia pacing and antiarrhythmic therapies, I think would also constitute Fontan failure. Before we tell someone their circulation is failing, we need to do our due diligence, look for obstruction anywhere in the circuit. So stenotic anastomosis of the Fontan conduit would be a commonplace. This can be stented, looking for branch pulmonary artery stenosis. All of these things are important prior to determining someone's circulation is failing irreversibly. So this complicated slide nicely demonstrates everything that goes into a failing Fontan circulation. We won't have time to go through all of it, but I think all of it is equally important. So because I've left things out doesn't mean they're not important. We won't talk about sarcopenia and decreased venous return and sedentary lifestyle, but those things are really important to helping blood get through that pulmonary circulation. So keeping our patients active, at a good body weight, healthy, exercising, all can go a long way. And pulmonary circulation, similarly, can have all sorts of issues, including elevated resistance, which we'll talk a little bit about, and shunts, which we'll also touch on. Fontan-associated liver disease and related complications like lymphatic abnormalities, kidney disease, are all very important and common in the adult population. And ventricular dysfunction, be it systolic or diastolic, is important. So for the patient in front of you who's not doing well, we do what we do for most of our congenitals. We do an echocardiogram, look at their function, we look for occult arrhythmia, we do cross-sectional imaging, look for obstruction, and a cardiac catheterization to evaluate their hemodynamics, and that will help guide treatment. This is a conceptual framework I like to use to help me manage the patient in front of me. So I ask the question, what is the dominant physiologic phenotype driving the Fontan failure in the patient in front of me? Is it cardiac? And if it's cardiac, is it due to systolic dysfunction or is it due to diastolic dysfunction? Is it non-cardiac or is it a lymphatic issue like PLE? The feature of the cardiac Fontan failure is pulmonary venous and hepatic venous congestion. And these patients typically have a low cardiac output and may have an elevated systemic vascular resistance. The type 3 non-cardiac Fontan failure patients are what got me interested in this 20 years ago. I would see patient after patient with a Fontan pressure of 12 and an EDP of 9, and I was told those are normal pressures, your patient's doing fine, but they would have ascites and edema and exercise intolerance, and you all are well aware of that picture, and I think these are the most challenging patients to deal with. And they typically have cardiac output that's normal. It might even be elevated. The systemic vascular resistance might be normal or it might be low. So these patients we don't want to treat like these patients because we're not going to get a good outcome. And then the protein-losing enteropathy, plastic bronchitis patients are probably related to all of these other issues, but they have a very unique presentation that requires additional treatment considerations. So the ventricular failure population, high EDP, lower normal cardiac output, may or may not have atrioventricular valve regurgitation, and they have this picture of pulmonary and systemic venous congestion. I treat these patients, and I will tell you that if you ask people across the country, you're going to find many people who disagree with me. I treat these patients with guideline-directed medical therapy for heart failure. And these are the from the 2022 heart failure treatment guidelines. For those who have reduced ejection fraction, I'm a big believer in beta blockers if they don't have a contraindication such as sinus node dysfunction that's not paced. I know there's a lot of controversy in using beta blockers in this population. We'll use an ACE, an ARB, or an ARNI depending on the situation for reduced EF patients. And for those that have either systolic or diastolic heart failure, diuretics, loop diuretics, MRAs, SGLT2 inhibitors are, the hot new thing on the market for heart failure, and they seem to work very well anecdotally in the Fontan population as well. I'd like to show you some good data from large randomized placebo-controlled trials of Fontan patients with exactly the same failing phenotype, but you're not going to ever see those. So the best we can do is extrapolate from what we know. Fontan patients have high neurepi levels from cardiac autonomic nervous system activity being increased in a failing circulation. We know if you give univentricular heart patients carvedilol for 11 months, you can make their heart smaller and improve ejection fraction and clinical status. Sinus node dysfunction, we have to be careful of, particularly in some of the heterotaxy patients. And that's it. I think that's the extent of the data. There have been a lot of studies looking at heart failure drugs with a CPX at baseline and a CPX after maybe 8 weeks or so of a drug, where there's no standardization of who's enrolled in those trials. And I think it's important to remember that when you give beta blockers to somebody with systolic heart failure, you're going to improve outcomes in that patient population without necessarily improving their VO2 max on a treadmill. So I'm a big fan, but I will tell you not everybody is. SGLT2 inhibitors, we have data from a case series of 14 patients, very large study, and those with reduced ejection fraction, Fontan failure, did seem to benefit clinically. So what about the normal heart patients? These I find to be the most challenging patients to take care of. It's very difficult to manipulate the circulation and make it work. And they can be very, very sick for a long time. So these patients typically have normal filling pressures. Their Fontan pressures typically are fine. And they have a lot of congestion on the systemic venous side. So varicose veins, hepatic congestion, ascites, they have exercise intolerance, and they go on to develop frank cirrhosis. And this is the more common type of Fontan failure in the adult population. This is more common than systolic heart failure. Uh-oh, why is this not advancing? Ah, there we go, now it is. All right, so Fontan-associated liver disease, I think, is a big component of these Fontan normal heart failure phenotype. And in the adult population, and in the adolescent population, fibrosis of the liver is common from long-standing hepatic congestion. Typical features are preserved synthetic function. It's unusual to see low albumin levels outside of PLE until very late stages. And they have hemodynamic changes at various points across their disease course. This is an adult multi-center study that looked at the liver in Fontan patients, and everybody had to have a biopsy to get in, and the liver biopsy was abnormal in all of the adult patients. And they had sinusoidal fibrosis, sinusoidal dilatation at a minimum. That was the starting point. They also looked at imaging characteristics. These first 5 bars are just ways of saying the liver looked big and scarred on imaging. But these are the ones I want to point out. 40% had splenomegaly, 30% had ascites, 15% had collaterals and varices. These here, this is scar. These are signs of a decompensated circulation. So these are very important. This is a study we did a long time ago looking at varices, ascites, and splenomegaly. And again, those who had 1 or fewer had a much better survival than those that had 2 or more on that VAS score. So these are a sign, a marker of a decompensated circulation. When you see those on imaging, it's kind of a red flag that they're going to have poor outcomes. So if you'll bear with me, can we talk about the liver? I know it's a cardiology audience, but. So we talked about imaging shows sinusoidal fibrosis. The central vein is also fibrosed, and you'll get periportal fibrosis. So this is what the liver looks like histologically. And this is a refresher on circulation to the liver. So here's your little Fontan path here. Here's your hepatic veins. These are under high pressure. From the perspective of the liver, the portal vein provides most of the perfusion to the liver. The hepatic artery provides less of a proportion of perfusion to the liver. When you have high hepatic vein pressures, you have high central vein pressures, and then you have high portal vein pressures. So you create basically a functional portal venous outflow obstruction. So it's not the same as a cirrhotic where those portal veins scar down within the liver, but the functional consequences are similar, where the portal vein flow can't get to the liver normally. So what happens? You have to perfuse your liver, you have upregulation of hepatic arterial blood flow. How does that happen? Let's see. Okay. How does that happen? Well, you have to have this splanchnic arterial vasodilatation. So the hepatic artery needs to dilate. You have to improve your splanchnic arterial blood flow through this vasodilatory process. And like everything in the body, it's not isolated to what happens on the splanchnic vasculature. So it's the whole circulation. So these patients then have renal hypoperfusion. So what happens when you have a dilated circulation with renal hypoperfusion? You then have to retain fluid to fill the circulation. When you retain fluid to fill the circulation, now you have to have a higher cardiac output in order to maintain that renal perfusion and not develop decompensation. So in a cirrhotic, those of you who do heart catheterization for liver transplant teams, the end-stage cirrhotic with portal hypertension, you'll see cardiac outputs that are 8, 9, 10, 13 liters per minute, very high cardiac outputs. And that's with a biventricular circulation with normal ventricular function. Now take a Fontan patient who cannot augment their cardiac output to those levels and sustain it. They're going to decompensate much sooner than your cirrhotic patient. So they may have hepatic fibrosis without frank cirrhosis, but because of this obstructed portal inflow from the high Fontan pressures over time, they will decompensate sooner. And that decompensation looks like ascites, splenomegaly, varices, and exercise intolerance. So what can we do about it? That's the million-dollar question, maybe billion-dollar question at this point. I like a cath in these patients to know what's going on, right? That's, I think, is really important. So if they have a low SVR, and many of them do, these are patients that typically have a blood pressure of 90/50 in the office. If they have a low SVR and a cardiac output that's normal or high, maybe their index is 3.5 or 4, I will put these people on midodrine as a vasoconstrictor to help improve renal blood flow, and then that augments the effect of the diuretics on the circulation. We use SGLT2 inhibitors in this population too, in addition to loop. I don't know if they help. I can't tell you they do, but we throw everything at them we can to relieve that congestion. The other important thing in this particular phenotype is that if they've been on an ACE inhibitor, and some of them have been since childhood to preserve the ventricle, this is the time to take them off, because this can be very harmful in this type of circulation. It can make them worse, harder to diurese, have more renal insufficiency. So the first thing we do is stop the vasodilators. If that doesn't help, we put them on a vasoconstrictor. But this is a sign of circulatory failure that needs to be considered a red flag. The other issue with Fontan-associated liver disease, as you all know, is hepatocellular carcinoma risk. And in the adult population, the risk is roughly 1% to 2% per year. We just looked at our Fontan population, and in the adults, over a 6-year period of time, those with liver disease, which is all of them, about 6% developed hepatocellular carcinoma over that 6-year period of time. So it's an important problem, but one of the things we can do something about is screen and do surveillance for these HCCs, catch them early, treat them early before they become problematic. These are guidelines from Europe, actually, on how to manage surveillance for the Fontan patient with Fontan-associated liver disease. And they advocate for ultrasound and AFP testing every 6 months, and they'll do MRI or CT every 1 to 2 years on top of that. If the AFP is high, they do CT or MRI. And if there's a new liver nodule, they'll biopsy it. If the biopsy is negative, they do screening 3 months later. So I think these guidelines, to me, make the most sense of anything that's come out. It's a nice algorithm to follow for HCC surveillance. Sadly, and I'm sure you've seen this as well, sometimes patients are out of care or they're not in adult congenital care. People don't understand the liver disease component, and they come in with metastatic HCC, which is very difficult to treat. I'm going to touch briefly on the pulmonary vasculature because it's not normal in the Fontan patients. We know there's remodeling very early and late, and this top panel shows that intimal and medial hyperplasia of the pulmonary arterioles in the Fontan patient compared to the bottom panel in a normal patient who does not have those findings. So you can see how thick that is up there. So we know it's abnormal. We also know that we have no data for treatments with pulmonary vasodilators, and we don't know who to give them to, and they can be harmful if they have high EDP. So the big question is, what do we do with this information? I personally don't use a lot of pulmonary vasodilators in this patient population because of the concern for harm, with the exception of those that we take to the cath lab and they have a clearly elevated pulmonary vascular resistance at cath, then we will treat them with pulmonary vasodilators. I think you could find plenty of people across the country who routinely use pulmonary vasodilators for this patient population. There have been, surprisingly, more studies of pulmonary vasodilators in the Fontan patient, more randomized placebo-controlled studies than there have been of the generic medications that are inexpensive. And a recent meta-analysis showed absolutely no benefit across all those studies. Part of it could be the enrollment. So are they enrolling a homogeneous population or not? Probably not. I think it's difficult to tease that out. Briefly on the lymphatics, Yoav Dori at CHOP has done a lot of pioneering work on protein-losing enteropathy and plastic bronchitis, and he would argue that the lymphatics are the issue with all of Fontan failure, and he would not be wrong. So I don't mean to minimize it by not spending a lot of time on it, but it's a whole hour in and of itself. But when your central venous pressures are high, you have impaired lymphatic return. And you have these elevated pressures in the lymphatic system, and then you start developing channels and leakage, and that causes plastic bronchitis and protein-losing enteropathy. In the adults, we see mostly PLE. Probably about 5% of the adults have PLE. Plastic bronchitis, I could count on one hand the number of cases that survive to the adult clinic, more of a pediatric issue. But he is doing some fantastic work with lymphatic embolization, which is really important treatment option, particularly for the plastic bronchitis patients. All of you that treat PLE, you're familiar with the pixie dust in the literature. So we have a waxing and waning disease, and then we have case reports that are biased towards positive results in a waxing and waning disease. So there's really very little agreement on what to do with these patients. I use budesonide for them with some success. I've had the most success with midodrine for these. And we published a whopping case report of 4 patients with PLE who, to add to the pixie dust literature, who responded to midodrine. Now, midodrine is an alpha agonist, and it constricts the lymphatics. So I think there's good reason to think it would work, because it will constrict those lymphatic channels that are leaking. One of those patients in that case series, he was on our transplant list, God, it's got to be 15 years ago. And we put him on midodrine. He was getting weekly albumin infusions, weekly IV Lasix, in the hospital all the time. He had immune deficiency related to the protein loss, and put him on midodrine. He got better, came off the albumin. His albumin normalized, came off the transplant list. For him, it was pretty remarkable. So we've had some good success with that. I don't know that it's going to work for every patient that we see. All right, so that was, a nice description of clean Fontan physiology phenotypes, right? So do patients have a clean phenotype? No. So let's talk about the real world. This is 27-year-old with Fontan failure. She has ascites that requires paracentesis about every 2 months when she's doing well. I'm going to talk about the cause of her heart failure in a minute. She's cyanotic. She has refractory intraatrial reentrant tachycardia. Her surgical history is remarkable for a left BTT shunt, which is important. I'll show you why. Bidirectional Glenn, lateral tunnel Fontan. She had obstruction as an adolescent of the Fontan, had stents placed there, had LPA stenosis related to the BTT shunt, had stents placed there. Her most recent cast, she had a Fontan pressure 25, ADP at 20, and cardiac index on the high side. Oh, we're sticky again. There you go. Thank you. All right. So because I'm on the adult side dealing with the consequences of these things, I would argue to my pediatric colleagues, if you're thinking about stenting pulmonary arteries that are too small or stenotic, think about whether or not you should also be thinking about transplant. So this is the consequence of the stent in this particular patient. The left upper lobe pulmonary artery is occluded completely. As a result, the left superior pulmonary vein is also occluded. As a result of that, she has developed AP collaterals like I've never seen, even in a pulmonary atresia VSD MAPCA patient. So she's developed this huge burden of aortopulmonary collaterals in the left upper lobe. Her pulmonary arterial sats at cath were 90. Torrential shunt from these collateral arteries. We've coiled them many, many times because she's had intermittent hemoptysis related to these collateral arteries for 12 years. And so she has these periodic coiling procedures to take care of those collateral vessels. She has vena-venous collaterals, of course, because her Fontan pressures are high from this torrential left to right shunt. And this contributes to her being blue, and these are just big, ugly, varicose vena-venous collaterals. Her liver, as you might have guessed, is cirrhotic. And she had a liver biopsy as an adolescent consistent with cirrhosis. She has features of portal hypertension on her abdominal MRI. She has focal nodular hyperplasia. She has not had hepatocellular carcinoma. She has varices, and as I said, refractory ascites. And I think I mentioned the refractory arrhythmias. She's in the ER getting cardioverted on a regular basis because her anti-tachycardia pacemaker, her antiarrhythmics, and her multiple ablations cannot keep her arrhythmia under control. She's also had esophageal varices needing sclerotherapy. So that's kind of the real world that we see in the adult population. So they have multiple competing issues contributing to their circulatory failure. Transplant, This young lady needs heart-liver transplant for healthcare policy reasons. That hasn't happened yet, but she'll be moving to a different state where it will happen. But transplant can be very effective circulatory support for the Fontan population. And it's very high risk, high reward. The best long-term outcomes, I think, for the population are achieved with transplant. Drink break. So the best long-term outcomes are with transplant for those with a failing circulation. And I think it's important to point out, if you look at survival curves for the Fontan patient population as a whole that does not have end-stage Fontan failure, their outcomes are similar to the outcomes with transplant. So I hear all the time from my pediatric colleagues, including my partners, that we have to transplant them when they're healthy, we have to transplant them early, it has to be done, they have better outcomes. It is absolutely true. When you transplant healthy people, they have a better outcome than when you transplant sick people. That doesn't mean 10 years from now that they're going to have a better outcome because you transplanted them. We have to be mindful that transplant is a disease in and of itself. It creates a whole nother set of problems that I'm gonna just briefly touch on. So transplanting them all early does not necessarily give them a longer and better life. So the reality, let's talk about the reality of transplant for a failing Fontan circulation specifically. These patients need reconstructions. It's a long operation. You have to fix the PAs, the cava. Sometimes things are stuck together. The most recent Fontan transplant we did required a partial lobectomy because everything was just stuck in there. They couldn't get the heart out. So they have long ischemic times typically because of this. They have veno-venous and aortopulmonary collaterals. The patient I just showed, I want you to imagine her aortopulmonary collaterals in the operating room, right? Torrential bleeding from these collaterals, and then they all have multiple sternotomies to boot. So they need a lot of transfusions. And we all know what happens when you give people a lot of blood products in the operating room. You're going to have complications related to that mass transfusion. Because of the cirrhosis and the portal hypertension that's common in the end-stage Fontan patient, they're more at risk for vasoplegia after their bypass run. So that can be very challenging to manage. So at the end of the day, they spend a longer time on the ventilator, they have more renal failure, they spend a longer time in the ICU, and they have a longer length of stay. And all of this impacts their one-year survival. This comes from a multi-center study with 131 Fontan transplants. And they looked at, and this is a small number, right, when you think about it. This goes back like 20 years, 131 from multiple centers. When you look at a more contemporary surgical era, one-year survival is 87%, which is really good compared to the 59% it was pre-2010. And 5-year survival is about 76%. So when we see the Fontan failing patient in front of us, we have to ask the question, what's their survival going to be at 1 and 5 years? Right? If they're in that super Fontan category, it's going to be close to 0. We shouldn't transplant them. If they survive the first year, conditional survival is very good. It's very similar to acquired biventricular heart failure. They do very well. They're young people. They have theoretically healthy organs. And I'm going to show you some of the risk factors that lead to early mortality. If they need renal replacement therapy, which is 1/4 of them, have an infection, 1/4 of them. Stroke, fortunately, is relatively low. If they need mechanical circulatory support post-transplant, which is common, 14% needed MCS post-transplant. Those are all associated with higher 1 and 5 year mortality. Median ICU stay, 11 days, length of stay 25 days. This is significantly longer than acquired biventricular heart failure patients who undergo transplant. We know, regardless of the indication, that your cardiopulmonary bypass time is associated with 1 in 5 year mortality, and we know these patients on average have a longer pump run. If they needed open chest afterwards, which is not uncommon, re-op for bleeding, not uncommon, all of these things increase mortality. These are the survival curves from that multi-center study. The one on the right, I think, is more helpful. The one on the left is the entire cohort. The one on the right is the 62 patients done after 2010, and that's the red line up here. And you can see survivals over time have improved as we understand the complications these patients will face at the time of transplant. It's probably good practice for every patient going to transplant, but definitely every Fontan patient going to transplant to have a multidisciplinary team meeting, probably more than once, to talk about this is what we expect in the operating room, these are the anatomic challenges, this is what we anticipate as the early complications, this is how we're going to manage these, and include the anesthesiology team and the critical care team that will manage the patient postoperatively. This paper also looked at risk factors that could be present at the time of evaluation. They all have the same theme. So veno-venous collaterals, lower extremity varicosities, low blood pressure, splenomegaly, varices, ascites, that keeps coming up. So these signs of portal hypertension, of a decompensated portal hypertension type circulation, are associated with worse outcomes. And then we run into the question of, do we do a heart or do we do a heart liver? Ask everybody across the country, you'll get different answers. We have, I don't know if any of you are part of the monthly heart liver working group that meets, that George Louis out of Stanford runs. No? We meet every month and talk about these patients. What do you do? It's a question, you know, do they need a heart liver? Can you get away with a heart only? Heart liver is a pretty morbid operation, it's a big deal. We are personally fairly conservative and will do heart only if there's no compelling indication to do heart liver. CHOP historically has favored heart liver for most of their patients, and they've had very good outcomes. So it's hard to know, I think, what is the best way to proceed with some of these patients. And I think the clear-cut signs that you need a liver, obviously hepatocellular carcinoma, but other things like refractory ascites. If they need frequent paracentesis, you may not be able to manage that patient without doing liver transplant. All right. So what's on the horizon? These slides Mark Rodefeld lent to me, which I greatly and deeply appreciate. I've followed his work forever. He's at Indiana University. I am aware something similar is in development here in Houston, but these are the slides that were shared with me, so I'm going to share his device. He has developed this really interesting concept of a cavopulmonary assist device. So this is a cavopulmonary assist device. It's biconical impeller. It's got this patulent channel around it, so you reduce your obstruction potential. If the pump stops spinning, you can still have flow that goes around it, which is kind of clever. It pulls, it's able to accommodate 70% IVC, 30% SVC ratio, and equally distribute the flow to the pulmonary arteries. It's small. It's designed to fit in, it's about, the adult version's about 20 millimeters. It's designed to fit in the cavopulmonary anastomosis. It doesn't require development of antechamber, if you will, like if you were to put a traditional mechanical circulatory support device in, it doesn't require that, and go right in the Fontan chamber. And the goal of this device is to manage those that have that primary Fontan failure where they don't have systolic heart failure as their primary problem. And in some early studies, they can get a gradient of about 6. So the normal Fontan circulation, you're upside down in your gradient, right? Your RA is higher than your LA. This allows them to generate enough pressure to improve pulmonary blood flow and lower, more importantly, the pressures in the IVC where the liver is. So it's a very clever thing. There's potential for wireless transcutaneous charging in future iterations of the device. They're also developing something in the lab that would be powered by the patient's systemic circulation. So I don't know how that's going to work out, but this is the one that's closest and furthest along in development. So you can see how tiny this is, and this is a video of the device here, SVC, IVC. Let me see if I can get it to play again. There we go. And you can see it mixes the SVC and IVC blood flow perfectly and spits it out into the pulmonary arteries. So it's very clever. The goal for this would be to develop something that could go in and stay in and not have the complications that the mechanical circulatory support devices we have for end-stage heart failure have. To do that, they have to achieve their goal of having no external wires to make this a reality. So it's a very clever little device, gives me hope for the future. I think they're still doing some mock testing, but hopefully I think they'll be in animal models soon. So I just put that out there as hope for the future because I know otherwise it's not a very uplifting talk. So I'm happy to answer any questions anyone might have.
Thank you, Dr. Book, for a phenomenal talk. We also have an audience, a virtual audience from many countries that were very excited to hear your talk. There is a huge appetite for educational opportunities, especially for advancement in the field, not only here, but in other countries in Latin America, Japan, Europe. So if anybody has any questions, okay. I have one here. And
Thank you so much for the engaging and insightful presentation. I have 3 questions. The first one is that regarding transplant, heart-only transplant versus heart and liver transplant. As you mentioned that in your institution you do single heart-only transplant. So one of the thought process is that with heart transplant, which is the heart is a culprit, the backflow improves and the liver function starts improving. So how do you see that in your experience, that it improves the liver function and the congestion? And the second point which you mentioned, that the idea is to get the heart transplant slightly later in life, in the adult life, because it also comes with a lot of comorbidities and complications of the heart transplant. So is there any age cutoff you discuss when you have the multidisciplinary meetings? And the third one is that because the adult Fontan failures are survivors, and in these patients, they are mainly Fontan failure with normal heart function. So do you also do transplant in those patients for lymphatic dysfunction or liver cirrhosis?
All right, I'm going to try to keep track of those 3. So, first question was, does heart transplant relieve the complications of Fontan-associated liver disease? The short answer is I don't think it reverses the complications. I think it stops it from progressing. And we monitor our post-transplant patients who were transplanted for a Fontan indication lifelong for hepatocellular carcinoma. We have one patient transplanted who 3 years after his heart transplant developed HCC. So we do monitor them lifelong. I think that risk persists because the liver is so scarred. But the hemodynamic issues resolve. How do we decide who needs heart liver, right? That's the big question. Those patients who have refractory ascites, for us is a red flag that they won't do well with a heart alone. So if they need paracentesis more than once, we're looking at them for heart liver in particular. And those patients typically have other features of a decompensated portal hypertension circulation. They typically have also splenomegaly and thrombocytopenia and may have varices. So any signs of advanced liver disease like that, we will think liver. Some centers will do the liver without those signs. And the third question was, how do you decide who to transplant and when? And I think that's the million-dollar question, right? I think in a pediatric population, there's good data that systolic heart failure in the kids has a poor outcome. So for the pediatric population, I think the question is answered a little differently. They may move towards transplant for systolic heart failure to avoid the early mortality that those children suffer. In the adults, we have survivor bias, right? So the ones with systolic heart failure that either died or were transplanted are not in our adult population. And in the adult population, we see more of these kind of pure Fontan failure, if you will, where they have relatively preserved function. I think there's definitely a role for transplant in those patients, even with normal hemodynamics, if they have poor functional class and have signs of decompensated circulation otherwise. The timing of it, that's anyone's guess. I think we can manage these patients very sick for a very long time, but when we do, they're going to be higher risk at the time of transplant. The young lady I presented as an adolescent, cirrhosis, varices, heart failure, right? We're 12 years out from that, and she's just now clinically decompensating, believe it or not, despite all of those other issues that she's had a long time. So should she have been transplanted as an adolescent? Is me the one managing her right now? I wish so, yes, but I don't know that I can definitively say that she would have been better off with that strategy. So I think it's a difficult risk-benefit equation for these patients. And then we have all the issues of listing status and getting them high enough on the list to be transplanted in a system that stratifies based on treatment. And we have a population that is not a candidate for the treatments that we're risk stratifying priority on, and it's a whole nother issue for these patients. So no age cutoff. I think the ideal time to transplant these people is when you think their 1-year mortality is going to be higher without transplant than with, which, when you think it's going to be 20% or so, that's the holy grail, is figuring out what that is. How do we create a risk score that identifies that time point? So I'll let you know when we do.
Thank you for a wonderful talk and all the tranquility emanating aquatic pictures. It's always good for us. I have a two-part question stemming from the hemodynamics as such. One, in heart failure related to left heart disease, we've come a long way in validating the need of hemodynamics, and finally we're winning the battle of convincing our interventional partners that we need a Swan-Ganz because it's the back circulation that makes a difference. We're also talking about venous capacitance, more so in heart failure, with devices on the right side that have kind of emanated the innovation segment. So my question in Fontan, the two-part is, one, is there a push to do more hepatic measurements, pressure measurements, translating into validating that inflecting point of when things go bad, which then leads to innovation of sensors that you can implant, like what we do for cardiomems. And to avoid this, my second part question is, has there been any changes in the Fontan surgery of today versus the past, either the materials used or the bypasses you're doing to avoid this back circulation so you're not stuck with the same Fontan problem 30 years from now?
Yeah, those are all excellent points. So measuring hepatic venous pressures should be part of all the Fontan caths with the hepatic venous wedge pressure. And if you have an elevated transhepatic gradient, that's one of the signs that you probably need a liver in addition to a heart with the transplant. Sorry, I keep touching the laptop. What was that last question? So sorry.
Leading into sensors to monitor in the long term.
Yeah. I mean, that would be awesome to have that. One of the issues, as all of you know, with looking at hemodynamics in the Fontan population is we are making decisions based on a supine, sedated Fontan patient. And for those of you who've been in the cath lab with the Fontan patient, the amount of sedation, the lack of sedation, the anxiety, the patient talking or moving, you can have these huge swings in the Fontan pressures. So we're making decisions based on hemodynamics that may not represent what's going on in that patient in real life. So I do think there is a potential role for hemodynamic monitoring in this population to really understand what's going on when they're upright and walking around, as opposed to supine in the cath lab.
Dr. Book, thank you for coming and excellent talk. I just want to get your thoughts on, and also a little of frustration as far as the listing issues with this patient and the wait time in this patient. You determined this patient need a transplant through patients, borderline EF, NYHA class 3B, is already developing a CKD, stage 3 fibrosis, but no cirrhosis HCC, so we can get away with heart alone transplant right now. CPET, VO2, max VO2 is like a 30%. So determine this patient need a transplant, list them, bigger patient, blood type O. The best we can do is list them as status 4 now. So, and the challenge been how, get this patient to transplant and what to do. They're not meeting criteria for getting a higher status. This patient, even if you get the status 3, they've been in the hospital waiting for a long time for transplant. So I just want to get your thoughts and where is the field and society is going to help this patient to get transplanted in the timely manner.
It's a huge problem when you look at criteria for each of the statuses, right? That you think, well, my patient doesn't meet criteria for any of those treatments, so how do we achieve that? There is published guidance for univentricular hearts to get a status 2 exception, and what those criteria are, like multi-organ failure, need for inotropes, continuous hospitalization is a component of that. So for single ventricle patients, there is guidance to get a status 2 exception. And if you follow that guidance and provide the documentation, we personally have not had any issues getting those patients upgraded to status 2.
Thank you, Dr. Book. Wonderful presentation. One of the things that we see often, or more often, with our failing Fontans is patients presenting with primarily cyanosis, which seems to be mediated mostly by venous collaterals or pulmonary arterial venous malformations. And by the time they're significantly symptomatic and they're brought to MRB, it's sometimes hard to get them through MRB because they'll say, well, they're too cyanotic, they won't survive the transplant, they probably need a heart-lung. And so I was just wondering, what is your approach to these cyanotic Fontans that seem to be at least overlapping or perhaps even a specific failing phenotype in and of themselves?
The cyanotic Fontan with shunt-related cyanosis, presumably normal pulmonary function or quasi-normal pulmonary function. I think In them, the shunt physiology reflects a failing circulation, and that will get better with transplant. Those collaterals will regress. The surgeons will have to deal with some of them at the time of transplant, but the venous collaterals will regress when you lower the venous pressures. So we don't consider lung transplant for them.
We have one more question here.
Thank you for your presentation. So I think we are coming from many decades of measuring gradients and pressure, but I think this is just part of the Fontan problems. I mean, the Fontan circulation is done by many pipes and a passive flow, and the energetic of the flow along the pipes is very important. So it's not only a matter of gradient. So I think that the 4D flow MRI can evidence if there are some energetic inefficiencies along the Fontan circuit. So let's say, for example, you put a stent in the LPA and the energetic of the flow decrease. So you can measure the gradient is 0, the surgeon is happy, everybody is happy, but still the patient can face a fast development of liver cirrhosis, for example, because the shear stress of the blood is very high. So I think we should focus more on the energetic of the flow and not only on the pressure. And to focus more on the energetics of the flow, we should use more and more the 4D flow MRI to assess the efficiency of the Fontan circulation and Fontan circuits. I would like to know what you think about this.
Yeah, I think that's an excellent point. From a practical standpoint, it becomes challenging in the adult patient because of artifact from all the coils and stents and pacemakers and everything else. But I think it's an excellent point. There, as I'm sure you're aware, a lot of interest in this, in the engineering schools in particular, to figure out the optimal flow dynamics for an individual patient. So I think it's a very interesting area, and I think we have a lot to learn from that. And the next question will be, how do we manipulate the flow to improve those flow dynamics?
Because just to come to you, Arvind, I read a paper recently, with minimal changes in the conduit design, you can increase the efficiency of the flow in an unexpected way, probably delaying the Fontan liver disease. So really with minimal changes of the conduit.
All right. We are 10 minutes over time. We did have questions from the virtual audience, but I'm sorry, apologies, we won't get to those. Thank you, Dr. Book, so much for honoring us with your visit.
Thank you for having me here. Thank you.